Welcome to the Sales Prospector Show, supported by Lease, a sales rep and a 5,000 company, helping our clients grow sales by securing guaranteed appointments, qualified leads, and guaranteed contracts for their services and products across the U.S. I'm your host, Gil Pagan. You can find us on all social media channels and at leaseasalesrep.com. Thank you for listening in. It's going to be a great one today.
Oh, it's going to be a great one today. Just like I said earlier, I want to have a great conversation here with Rich Prest, who is the Senior Executive VP of Corporate Strategy. Man, that's a title and a mouthful there. Of AssistRx, which is a really interesting company that has a great technology platform that somehow streamlines the process of medical providers, doctors, getting certain medications to certain populations, vulnerable populations, in a, I guess, a quicker type of way, and reimbursement and tracking it, and real exciting stuff. Hopefully I got a little bit there correct. Rich, welcome to the show.
Thanks so much, Gil. Yeah, it's definitely an interesting space we're in. It's probably surprising to people that with all the advances in science that we see, these amazing biologic medicines, that the favorite piece of technology in the doctor's office is the fax machine. And the guys that founded that company, when they started this 10 years ago, they'd run specialty pharmacies, and they were just frustrated with all of the paperwork that it took to get a patient. The doctor's gone to all the trouble of working out what's the best medicine for the patient. They've written the prescription, and then all of a sudden, you've got this last mile issue of how do you actually get the patient started? And there's a whole heap of paperwork that has to be filled out. And they thought, well, surely we can move away from fax machines and paper and do this electronically. And that's the key part of our technology platform is really providing software to help the doctors make that whole paper-based process electronic.
Well, that's great, and I can confirm this for our sales reps in the field. When they go into doctors' offices across the country, they still see fax machines, and it's still done. It's still the way that many doctors still do business. The one in the private practice kind of settings, right? And they've moved to EMRs and things like that, electronic scripting. But there's still a lot of paperwork stuff that still is done the old way, if you will, and safe.
Yes. Yeah.
It's in a file, right?
Well, that's exactly right. And although most scripts have moved to electronic, if we look at volume, I think we're, well north of 90%. Yeah. The whole paper file. And so, what's interesting is we've got a lot of medicines today. The bulk medicines are these low price generic medicines. Over 90% by volume is generic. It's low dollar cost. It's all electronic. It goes through to your Walgreens or CVS or your preferred pharmacy. Everything's electronic. But when you get into these higher price specialty medicines, the oncology medicines, rheumatology, et cetera, there we're talking these much more expensive medicines, $1,500 a month, $6,000, $10,000, $15,000. We've got medicines now that cost more than $1 million a year. And because of that high cost, of course, the insurance companies want to make sure everybody's covered before they start reimbursing. And also, if you're a provider, you don't want to have a medicine dispensed and not know that you can get reimbursed for it. So the crazy piece is there's all this science in these specialty medicines, but when it comes to the prescription process, only 15% of the prescriptions go electronically. Everything else is paper. And that's because of all these prior authorization forms, the enrollment in the programs that manufacturers offer, these patient services programs, et cetera. So there's a lot of paperwork that we have to get through, and that's why the prescriptions are for the vast majority still done by paper and not electronically.
Yeah, I'm sorry to interrupt. So the 90% of the medications that you and I would get when we go to a doctor's office, just for people who understand the way the healthcare industry works. I mean, if you go to the doctor's office, you get an antibiotic, you get a cholesterol med, maybe even a diabetes med. They do that electronically. You walk into CVS, Walgreens, it's there for you. You pick it up 90% of the time. That's the standard operating procedure, right?
Yep.
For you and me, you know, we're healthy, thank God, and we go and get our meds,
Yes.
right?
Yeah.
But if you got lupus or you got
Yep.
multiple sclerosis or you have what is it, the some kind of cancer,
Cystic
rheumatoid
fibrosis,
arthritis,
oncology, yeah.
right? You have that kind of, you know, disease that the process to get medication like that, meaning you said some of them are, you know, $1,000 a month, some of them could be $1 million a year in treatment. That's a whole different process, and specialty pharmacies are involved in that process, right? So can you take us through? So the doctor is going to write a script for rheumatoid arthritis, right?
Right.
And now he or she is going to go through a process. And what happens? You go to the doctor's office, you need that script. What happens from that place to the time the patient gets it, and how you guys are in the middle of all of that?
Yeah. So it is surprising to people, right? Because they're thinking, okay, doctor's written the script and I'm just going to send them down to my local CVS or Walgreens and it's all going to be easy. And then suddenly it's like, well, if CVS, for example, has a list of about 500 specialty medicines, and if a script ends up at a local retail CVS, they will in fact let you know, hey, this is actually on our list of specialty medicines, and our central specialty pharmacy that serves the whole nation is going to call you, go through all of the checks and balances and make sure everything's squared away, and then they're going to ship it to you. And so that's from the patient's perspective, the first thing that they're going to see when they get on these specialty medicines is the doctor's office is ideally going to talk to them about the fact that this is a more complicated medicine. There is a different process, that it's going to be filled by what's called a specialty pharmacy that isn't a pharmacy you can walk into. It's a pharmacy that's essentially a mail order pharmacy that's going to call the patient. And that because the medicine's quite expensive, that the manufacturer has a range of special programs that help with getting access to the medicine. So what they're going to do is they have what's often called a hub, and that hub is going to be available to connect the patient with any of the special access programs that are available. So if there's some delays in getting access to the insurance benefits, so they can put them on some free drug, some starter drug to get them going. If they don't have any insurance, they may qualify for free drug. If there's copay programs that the manufacturer offers, and for most of these expensive drugs, of course, manufacturer offers a copay program, so they'll explain that and make sure the patient's aware of it. And so it's essentially they're going to ask the patient to enroll in the programs that the manufacturer offers, and of course, with all of the controls that we have over our healthcare information and making sure that's kept private, that for any of these groups to be involved, patients have to sign off and say, look, I understand I'm getting these services, that you're going to communicate with me and that you're going to exchange my healthcare information in order to provide me with these services. And so there's a lot of consent that needs to happen, enrollment in these programs. We have to do benefits verification. We have to potentially do prior authorization if the insurer requires it, to make sure that they're actually gone through all the necessary steps and balances. So, and then connect them with the copay program. So essentially, I mean, already I'm realizing this is a complicated explanation, and we, it's doctor's office ideally says, okay, here's the programs that are available. They fill out the forms, and then it gets faxed to the specialty pharmacy. So that would be the way it would typically happen, right? And so it's all on paper and fax machines. The process that we offer to the doctor's office is that instead of doing all that paperwork, what they would do is pull the information from the EMR for the patient, pre-fill these forms to the extent available, have the patient e-sign the form, and then they're going to press the submit button. It's going to get sent to the hub if necessary. Our hub, if we're running the hub for the program. We're going to help the doctor's office if they want any help. But they'll need to initiate the prior authorization for the drug. But again, we have all of the technology so that rather than having to call the insurance office, they can actually do an electronic prior auth through our software. They can do a real-time pharmacy benefit check through our software to actually find out what the what's covered if it's a pharmacy benefit drug. And then that set of documents can get sent to any specialty pharmacy to fill that drug. So that can be the patient's choice or the provider's choice or the insurer's choice, but they can send it anywhere to then get it actually dispensed. So
your platform, iAssist, right? So your platform is a benefit, or a lack of a better word, correct me my terminology here, is a protection for the manufacturer of the drug or for the insurer of the so the doctor writes the script for rheumatoid arthritis, for the medication, and then they send it out, and you're coming in to make sure that they can qualify or take care of the qualification for any subsidies or coupons or reduced rates, and so are you basically protecting, forgive me for my terminology, are you protecting the insurer from getting a drug that they're not going to pay for? I mean, help me to understand, because you're the doctor, the front end is doctor, but help me to understand that.
Really, what we're trying to help the patient and the provider. The manufacturer is paying for the service because they want to make sure that the patient the appropriate patients get on drug. And so if the doctor's done all the trouble to select their drug, they'd love to see that patient end up on the drug. So we're sort of solving this last mile problem. And the way we're protecting the provider and the patient is that by checking with the insurance company to make sure that they've got benefits coverage and doing any of the prior authorization with our software, then they're able to go through all the necessary steps that the insurance company wants, the payer or the PBM wants done, before we go to taking it to the pharmacy to actually get it dispensed. So ideally it goes to the pharmacy, and at this point we know for sure that the patient has insurance coverage for this drug and that they've got the necessary authorization to have the drug be dispensed. So that protects the patient in the sense that we make sure that they're getting they're only getting, they know what their out-of-pocket will be, and we've worked out whether they can handle that. And it protects the provider's office as well, because it makes sure that they don't have the hassle of sending a patient to a pharmacy and discovering that they can't get the drug because they're not covered or they can't handle the out-of-pocket. So that's really the point of doing the benefits verification and the prior auth, is to make sure that the patient understands the out-of-pocket, they can handle it, and we've got the necessary assurance from the payer or the PBM that they're going to cover it.
Right. So you're basically the front end part of it, making sure that obviously the patient gets the benefits of all the programs that the manufacturer may have for this very expensive drug. Let's say $1 million a year drug. I like to know what that is, by the way. $1 million a year drug, right? And then once that the insurance is going to pay $500,000, just say as an example, of that $500,000 is left. And then another $100,000 of offer is going to come from the manufacturer. So now the patient's on the hook for $400,000. And I don't know, they're on the hook for the $400,000 with the insurance or with the manufacturer.
So look, there are some very expensive drugs, and hemophilia is an interesting one, right? Because depending on the particular patient, that is a case where you do have some hemophilia patients that run $1 million a year. Some of the newest cell and gene therapies can get very expensive. Some of these are actually cures for diseases. So there was a gene therapy that came out recently for a particular rare blindness disease, and I believe it was I can't quite remember, but I think if you did both eyes, it was over $1 million for that. Now, I mean, this is the challenge with these sticker prices is that everyone sees those numbers and is appalled by that. But I think the question is, what's the value of curing blindness over somebody's life? And, you know, I think that the one that really spurred this all off was when Sovaldi came on the market for Gilead to cure hepatitis C. This was a drug that, you know, was priced at $84,000 list, and it was a 12-week subscription. It caused all sorts of furor because there was so much volume. There's so many people in the country that have Hep C. The chance to cure all of these people and avoid liver transplants was seen. You know, the pricing was done very much on this idea, well, you know, the cost of managing these patients over their lifetime, and if they have to do a liver transplant, is well in excess of $84,000. So therefore, you know, this is a decent value exchange because we're curing them. But everybody saw this price and was just like, oh my God, how can you charge that much for a tablet, right? So it's, you know, value and cost are things that always cause challenges in our society, I think. And I think, yeah, drug prices are extremely complicated issue, as we know. And I think just recently we saw, you know, Trump pushing ahead with some, you know, a hope to make some shift on drug pricing. And it's tough because I think we also see the value of innovation, and that the US in many ways shoulders the cost of innovation globally. So it's a very complicated issue. And I think the other thing that people forget is that drug pricing is only 15% of the cost of healthcare in this country. If you really want to go after the where all of the dollars are, look at health systems. You know, 65% of the cost of healthcare is tied up in health systems, and you know, I think we should be looking at those costs and not just focusing on drug costs, because taking 1 or 2% off the 15% isn't going to move the needle on the cost of our healthcare in our country. Whereas taking that same percentage off the cost of the health systems would have a much more significant impact in terms of savings for us.
Yeah, clearly the cost of running the health system and the infrastructure to run that, those huge buildings and staff and all type of procedures, and it's clearly a monster, what I call the healthcare industrial complex. Which is just like it perpetuates itself because it employ, you know, millions of people across the country, and sometimes is the biggest employer in a small town that has 5,000 employees in the hospital, you know, and they're the employer, and you see this cost structure, how it was attacked during COVID, where the elective procedures were eliminated because of COVID, and you realize that all of their, most of their billing was elective procedures, not necessarily urgent care, which is very interesting. That you would think that it should be more urgent care and not elective, but that's a whole psychological, societal kind of thing, you know, which I find interesting.
Yeah, no, I mean, the whole healthcare system and how we make it more cost effective is, you know, we could talk about for years. It's, I think there's many causes for the high cost of healthcare, but I think we've certainly seen in COVID that with the reduction in the amount of diagnostic tests that are done, plus the reduction in elective procedures, that has caused many of these health systems to go into the red and be extremely financially challenged. And I think it's also made many of the doctors start to question, as they've shifted to virtual care, to start to say, well, how much of this stuff that I really need to do, and what's really in the best interest of the patient? And I think that's, you know, it's the big question everybody's got is how much of that's going to come back, because for the doctors that really care about only doing what's in the best interest of the patient, are they going to cut back on some of these things going forward if they're not completely necessary?
No, absolutely. Does the platform itself, iAssist, does it plug in as a bolt-on, as I call it, onto an EMR platform, or do you
Yeah.
have to, log in? I know you said earlier you pull in data for the forms from
Yeah.
EMR. So can you
Yeah.
explain that a little bit?
Yeah, so for sure. So it's free browser-based software for the doctor's office. Because we're SureScript certified and because you can actually write prescriptions on the software, we want to make sure that the people that are using it are actually valid, authorized prescribers that and have a valid MPI number. So we do go to the process of checking their identity and making sure that's meets SureScript standards. And so there is an initial log-on procedure. Their authorized office staff are able to use the software on behalf of the doctor. So we also have a login procedure for those office staff members. With respect to the EMR, there's various ways for us to pull data from EMR systems, and that's certainly, as you know, EMRs are a complex area. It's the new interoperability rules are certainly going to help a lot with making that data more readily available. Because in the past, it's been a case of you don't just do an integration with Epic. In the past, you had to also do once you went into Epic, you then had to go to each health system and say, well, what customizations have you done to Epic? And then, how would we pull that data? So I certainly wouldn't say we're at, got a complete solution with respect to EMR data, but wherever we can, we want to pull that data and pre-fill the forms to make it easier for the prescriber's office.
Are you guys at all going to be affected by the pricing and patient transparency act that's going into effect next year, and how pricing needs to be, I guess, bundled in certain instances at the hospital level, and that's going to include drugs and all this kind of stuff? You guys affected by that at all?
Well, I would say we would encourage more transparency in this area, and as we're doing with real-time pharmacy benefit, we're attempting to provide this pricing visibility around what is the patient out of pocket and for the drug. Because I think that's one of the other things that's very confusing for folks is that the list price has got nothing to do with the price that the patient ends up paying, other than perhaps that their copay may be calculated off that list price. And so, we're certainly keen to continue to show as much visibility as possible. So the impact for us will be working along with that and making sure that we're helping to show prices and provide transparency in this area. Yeah.
And I guess, and just from your knowledge base, just personally, and what you know about this, I don't expect this to make any policy decisions here, but when you're dealing with these kind of drugs that are very expensive, and the hemophilia and the Humira, some of the these diagnoses, and the patient that is diagnosed with this either doesn't have insurance or they are on Medicaid, right? Medicare tends to be better because everybody drives their cost structure around Medicare, right? It's kind of like the monster gorilla in the insurance market. But people don't realize that Medicare is the big gorilla, right?
Right.
And then you got all the other insurance companies around that. But what happens in a situation like that when a patient is diagnosed with one of these really chronic illnesses and they don't have insurance and they have Medicaid? Help me understand how they go into your hub. Then what happens?
Yeah. So
they spit them out with a drug.
Yeah. And a lot of the manufacturers have quite generous programs with respect to providing free drug. So when you get to patients that are uninsured, typically most of the manufacturers have some guidelines around the multiples of federal poverty limits that they provide drug under. So it may be 3, 4, or 5 times the federal poverty limit is the threshold that they set for an income test. And so in the case of a patient that's uninsured, they would look at the federal poverty level and the income of the patient. And if the patient qualified, then they would make available free drug. And we, for example, have a non-commercial pharmacy that provides free drug for several programs like that. And, that's a really important part of helping patients out. And, another area we do a lot of work with Gilead and actually now with the government in terms of providing, Gilead's made a ton of drug available for Truvada and Descovy for PrEP, for HIV. And, a lot of the intention there is to help patients that might be at risk and to provide them with free drug. And so we run some programs to help in that area as well.
Do these companies have like I don't know, and then again, no company in particular, but do these companies, pharma companies, have like a limit on, free drug they would give out every year? And they may say, okay, we're going to give 100 patients, whatever they need for that drug, 10 doses, 100 patients.
Yeah.
When you get that cap, you got to wait till 2021. I mean,
do
you know if they have that or not? I would think so.
I don't think I've ever seen anything like a cap on that. I mean, I think that the reality is that free drug is usually about 5% of volume, and it's just one of the costs of doing business. So I think, pharma, when they look at the list price, they understand that you've got drug that's going to go to 340B that's going to be discounted anywhere between, starting at 23% down to, I think Humira through 340B costs like a cent, right? And so, the health systems are making thousands of dollars on patients that are on Humira through the 340B program, but the manufacturer is making close to zero on that drug that goes through 340B. So it's again, it's this complicated. Yeah. So very much the list price is not what's paid, and different depending on the insurance coverage, it varies tremendously. I think the other one we didn't cover was the Medicaid patients often have, Medicaid gets the best price, and it's often a very, very low price. So the out-of-pocket for Medicaid patients is not typically a big issue. Actually, where the out-of-pocket for government patients is most challenging is with Medicare, because that's an area where the government had not allowed the pharma companies to offer copay programs or copay offset programs. And for the Part D drugs that are the pharmacy benefit drugs, there's often a 20% out of pocket, which, as we were talking about before, you talked about some of these drugs, even $1,000 a month drug, that's $200 a month. That's substantial for many, many, many people. And if you go to a $10,000 a month drug, now we're talking about money that a lot of people just couldn't afford. So I think that's one area where it's been, and I mean, you put in place these incentives and it impacts behavior. There's drugs that, these subcutaneous drugs that could be self-administered or administered by an HCP. A pharma company has to make a decision about whether they're going to run it through as self-administered or as HCP administered, because if it's administered by a doctor, it's going to be a medical benefit drug, and therefore it'd be under Part B, as in boy, and therefore there'd be less out-of-pocket issues than if it was running through Part D. So it's just crazy complicated, and I think we end up with a lot of people out there suffering because they can't get access to the medications that might be best for them because of these many different pricing rules and how insurance coverage, et cetera, impacts what they're able to do.
Yeah, wow. When you talk about timelines with your platform, so the doctor diagnoses a chronic illness and they write the script that has to go through a specialty pharmacy. And just for the audience perspective, specialty pharmacy could be located in any place, basically, in an industrial area or business area. And you can't walk in, like you said earlier. And it could be in a warehouse. and we got pharmacists, licensed pharmacists working in those places.
Exactly.
But it's not a retail kind of place where you go buy Tylenol. So it goes to this place eventually once they get through you, I think. So how long does it take for a doctor or the patient to actually get the med that they need from when they start with you and then they get it to their doorstep? How long does that take?
Yeah, and again, this is one of these ones where it varies, right? What we're trying to do is accelerate that process. So that the metric that we call time to fill, we really want to, by doing electronics benefit verification, electronic prior auth, we want to cut that process down from, especially once you get into prior auth, and it can take weeks. And so if we can do that electronically, we can get an answer straight away. We can do benefits verification straight away. We want to be able to turn that script around and bring it down to a matter of days between the script being written and the patient getting the drug. And that's the longest pole in the tent is usually this issue of the insurance company and how long they take to approve the drug. And if there's a denial and then you've got to go back and get more information and go back and appeal the denial, then that obviously adds time. Medical benefit drugs typically can't be done electronically. That's one area where the industry's, a lot of work being done right now to go from phone and paper-based medical benefit prior auths to electronic, because that's just taking too much time, and checking the benefits for medical drug. So yeah, we really want to shorten that from weeks down to days, because I think that's where, the quicker we can get patients started on therapy, the quicker they can start that process to getting better. And so, certainly something that we see as a huge benefit of moving to electronic process. The other one that's quite surprising is about 30% of the forms that come in by the fax machine, typically missing information. A lot of that missing information can be signatures. And then when you reach back to the provider's office to try to get that missing information, those signatures, often it can be quite a difficult process. And so it's surprising how many times the forms come in not complete, and it's a difficult process to actually get back in contact with the prescriber and the patient and get the necessary information so you can continue the process. So I'd say the other big delay with paper is just can't reach the prescriber or the patient, which sounds crazy, right? They ask for it and now you can't reach them, but that is another common cause of delays. So again, a benefit of electronically submitting it is we can get it, we can check it straight away, and generally, if it's submitted electronically, we can also make sure the fields are completed before it's submitted. So just the same as if you're doing a checkout for something you're buying on Amazon, if there's anything missing, they'll make sure you fill those forms in before they take the order. Same sort of thing here. If we can get the forms electronically submitted, we can check they're complete before they get sent.
So your model, your sales model, to get this platform, which is needed obviously to streamline this process of getting the meds to the patient as soon as possible, and obviously taking care of all that insurance stuff and coupons and vouchers and programs. So your sales model, so you need to talk to. If the doctors are the ones that are using this on the front end, then you need to speak to, I guess, specialty practices that are ordering. So these meds like oncologists, endocrinologists, maybe even neurologists. I mean, all these kind of subspecialties to get in front of them so that they can use iAssist for their patients. Is that accurate?
You got it. So we have a team of folks that were in the field before our COVID came along, and also some folks on the phone, and they are constantly in contact with providers' offices to try to help them to get started with the software and then be able to take advantage of this electronic process as opposed to the paper-based process they use today. Yeah.
You know what's interesting is that a lot of practices are still using paper processes, and the sales process, this is not a sales pitch for you, the sales process is still the same. You got to get out and get in front of a doctor, talk to a practice manager,
Yeah.
a phone call. You still got to, that process is still the same,
Oh,
although,
for sure. Yeah.
although, go ahead.
Yeah, no, I think I've watched a ton of, presentations, webinars on the shift to virtual detailing. And I think, that's going to work with some offices, and it's clearly, I mean, we've already seen with health systems that a lot of health systems don't let sales reps on the territory, and manufacturers have had to learn how to shift from, having a sales rep go in and try to talk to the doctors on site to more of an account-based sale with the health system. But then, the other challenge here is how do you actually get the contact? Where do you get the email from? Where do you get the phone number? How do you, they're getting 1 million emails a day requesting this, that, and the other service that they have a look at. So how are you going to make sure they actually listen to you? And so I think that transition to virtual detailing is a tough one. And I think a lot of, there's a substantial number of providers that are going to continue to want to have an actual meeting with a sales rep, because they would rather than having to do the online research themselves, they prefer to spend a bit of time with different sales reps from different manufacturers, hear the different perspectives on the therapies that are available, and then make a decision about what's best for what patient.
I agree, and we figured out some strategies. I will not share them on this recording. How to get in front of some of these systems and get around some of these kind of barriers they threw up. We sell in the healthcare space, right? So we kind of doctor's office not that complicated. You can walk in and set something up, and phone calls, but the systems in the hospitals and some of those big decision makers, they're stopping you at the gate at times, and they say no entry for you. Big sign with the circle. No sales reps here. But I agree, and I think the pharmaceutical industry is the one that started the process of getting reps in front of doctors and giving them free samples and giving them a lunch and get some pizza, and then the rep can answer all the doctor's questions 1, 2, 3, 4, 5. Doctor's got his information. He gives it a shot. Then he moves forward with it. I agree. I think doctors want that quick information. Give it to me. Give me a paper. Give me a link. I'll read it 2, 3 pages about the drug, and then let's give it a shot, and I'll monitor my patient. As long as it doesn't, adversely impact the patient's health, and give it a shot from there. But I agree with you. So if you had to summarize here as we wrap up, our conversation, I'm going to do my best here to do this. What we just talked about in so complex, but that we covered today, that iAssist helps medical providers, particularly in specialty areas, treating chronic illnesses with high-ticket medications. They help those providers streamline the process of getting the drugs to their patients, and iAssist does that by an electronic benefit verification. They do that by prior authorization, make sure that the patient is covered, and then also throw any programs that the manufacturer may have on that high cost drug, so that the patient knows his out-of-pocket or her out-of-pocket is going to be X, and streamlines that process as fast as possible to get that medication to the patient.
Oh, well done. That's nicely summarized. Yeah. When do you want to start calling? When do you want to start calling on providers' offices for us?
well, thank you. I'm humbled. You guys are doing some great stuff. It's a great program. And
thank you.
enjoy chatting with you. And I want to ask you one lightning round question. I got a
Sure.
whole bunch of them. I'm just going to go with one. If you had one superpower that you could have right now, what would that superpower be?
Oh, wow. Gosh, I think providing, I think helping people to understand the, if I could help people to understand the complexities of drug pricing and the journey, somehow make this complex process comprehensible. That would be the superpower.
Well, that'd be a superpower for sure. Well, thanks so much. I enjoyed having you on the show, and I enjoyed this conversation. I'm sure people will enjoy what we discussed, given we shed some light on how this system works and exactly what you guys do. Wish you the best in your rollout and your expansion. May the rest of this year be extremely successful for you, and going into 2021 as well, but you blow the doors off the industry and grow this company.
Thank you so much, Gil. I really appreciate it. Appreciate the time. The conversation was great, and hopefully this has been helpful to your listeners. And hopefully we've helped a little bit in terms of shedding a light on this complexity.
Absolutely. Thanks so much.
You betcha. Cheers.